Assalamu alaikum and good morning. Welcome you all to my academic channel Plastic and Hand Surgery by Dr. Nurunnahar Lata. Our today's topic Dupuytren disease, also known as Viking's disease. Few years back, I prepared this lecture for our plastic surgery phase B residents. I just tried to coincide the slide and prepared it suitable for YouTube upload. Hope it will be helpful for all who want to know about the Dupuytren disease. Dupuytren disease is a progressive disease of the palmar and digital fascial structure. It is characterized by nodular thickening and subsequent contracture. Though it is not that much common in our country, usually it is called the Viking disease and more common in Nordic population. But very often we get the cases and obviously in advanced stages and usually we manage by fasciectomy. What happens here? Usually deformity of the hand occurs at metacarpophalangeal and proximal interphalangeal joint. It is a challenge for hand surgeon, the treatment and prognosis, because prognosis is not that much good and recurrence rate is high. Dupuytren belongs to overarching category of benign fibromatosis and closely related to the Peyronie's disease, that is penile fibromatosis, and also Ladder-Hose disease, plantar fibromatosis. Historically successively referred to as Nordic, Caucasian, Anglo-Saxon, and finally the Vikings disease. Incidence is highest among individuals of Northern European ancestry, ranging from 2 to 42%. If we follow the epidemiology, Dupuytren affects population throughout the world. Male are affected 6 times more than the female and onset usually at 5th decade of life. Female are usually affected on 6th decade. Pattern is autosomal dominant with variable penetrance. It is also associated with repetitive trauma, alcohol abuse, smoking, hepatic disease, diabetes mellitus, smoking, chronic obstructive pulmonary disease, malignancy, and epilepsy. If we consider pathophysiology, Dupuytren disease ultimately manifested as transformation of normal palmar and digital fascia to thickened disease cord through the deposition of type 1 and 3 collagen. And contractile forces here are generated by myofibroblast. An intimate understanding of native and pathologic anatomy is paramount in assessing and appropriately treating the patients with Dupuytren disease. Palmar fascia usually provide flexible but firm framework for soft tissue of the palm. It consists of two distinct layers: deep fascia not involved in Dupuytren disease and superficial fascia or palmar aponeurosis affected by pathological progression of Dupuytren disease. This palmar aponeurosis is a triangular structure, consists of longitudinal, transverse and vertical fibers. Apex is continuous with the palmaris longus tendon. Longitudinal fibers are superficial to the flexor retinaculum, forms the pretendinous band. Within the palm, the pretendinous band form pretendinous cord, which is the primary contributor of MCP joint flexion contracture. Transverse fibers form two bands. Proximal band at the level of the distal palmar cage not affected. Distal band or natatory ligament affected by the Dupuytren disease. Natatory ligament extend from the radial border of the index to the ulnar border of the little finger. On the underside, natatory ligament divides to envelop the abductor digiti minimi and ulnar neurovascular bundle, and radially it is continuous with the distal commissural ligament of Grappo within first wave space. In Dupuytren's disease, natatory ligament forms natatory cord that causes wave space adduction contracture. Vertical fiber of the McGraw and septa of the ligure and javara connect the superficial palmar aponeurosis to deep fascia and causes painful triggering of fingers. The fingers is invested by elliptical fascia covering consisting of volar and dorsal fascial sheet. The volar and dorsal aspect of the finger are separated by series of lateral structure that envelop neurovascular structure of the fingers. These are Cleland's ligament, Grayson's ligament, and transverse reticular ligament. Here the picture showing the Grayson ligament, lateral digital sheet, a spiral band, and pretendinous band. In palmodigital region, the spiral cord formed from pretendinous band, a spiral band, lateral digital sheet, and Graham's ligament displays neurovascular bundle. In the finger, the pretendinous band becomes central cord and causes PIP joint flexion contracture. In the first wave space, proximal and distal commissural ligaments become cord and causes first wave space contracture. In 1959, Lukes described the pathogenesis of Dupuytren disease. There are three phases: proliferative phase, involutional phase, and residual phase. What happened in proliferative phase? Here, formation of nodule occurs within the palmar fascia, increased fibrinolytic activity, and differentiation of the fibroblast into myofibroblast and causes formation of nodule. In involutional phase, type 3 collagen synthesis occurred, marked nodular thickening and early joint contracture. And in residual phase, myofibroblasts disappear, type 1 collagen replaces the type 2 collagen. Diagnosis of Dupuytren disease usually clinical. No imaging or histopathology usually needed. Characteristics: progression from nodule to fibrotic cord with contracture of the affected palm, and the digit is pathognomic for Dupuytren disease. Pitting or dimpling of the palm with distortion of the distal palmar keys, that is called Hugh-Johnson sign, is the earliest sign of Dupuytren disease. Nodules are commonly located ulnar side of the palm, overlying the ring finger at distal palmar crease and proximal interphalangeal joint. It is painless but may cause discomfort. Also, longitudinal cord develop at the ulnar aspect of the palm. There is also short Watson sign, that is displacement of the neurovascular structure. Here, ring finger is most commonly affected, followed by little finger, thumb, middle finger, and index. Ultimately, progressive disability of the hand occur due to MCP and PIP joint contracture. Distal interphalangeal joint is typically unaffected. Patients usually present with impairment of handshaking, fitting of gloves, difficulty in placing the hand in the pocket, and impairment of grasping of long object. Now we will discuss about treatment. Objective of treatment is correction of deformity, reducing the disability, and restoring optimum hand function. Treatment usually subdivided into modality therapy, injection, and surgical intervention. Indication for surgery are more than 30% of the MCP joint contracture and any degree of PIP joint contracture. Functionally limiting first wave space contracture. Little finger abduction contracture. Unremitting tenosynovitis secondary to palmar nodule over A1 pulley and palmar contracture resulting in maceration of the distal palmar crease. In modality therapy, we usually did extension splinting. Patients should wear splint continuously to prevent contracture. Here, intermittent splinting is not that much effective. Ultrasound therapy causes softening of the nodule, but it has no effect on treatment of the contracture. We can also give external beam radiation and others additional therapies. Injections. We usually give a steroid injection, though its efficacy is a matter of debate. First given in 1952. No efficacy to complete resolution of the palmar nodule. No role on cord or contracture, but there are some complications: dermal atrophy, skin depigmentation, and flexure tendon rupture. Then comes enzymatic degradation. Some authors use degradative enzyme, such as in 1971, Houston used trypsin, hyaluronidase, and xylocaine. He got favorable result. In 1996, Clostridial collagenase was used and some authors got good result, but there is complication of tendon rupture. And after injection, night splint was advised 4 months following injection. But these options are suitable at early stage of the disease when there is no definitive cord formation. But in our country, we usually get patients at advanced stages. There is definitive cord contraction and contracture. So we go for surgical treatment. Here, two options are available: fasciotomy and fasciectomy. In fasciotomy, division of the disease cord without excision. It can be done in two ways: open technique or percutaneous. And in fasciectomy, what we usually do, there is excision of the disease cord. Percutaneous fasciotomy was first described by D. C.G. and De Beer in 1957. They did direct injection of corticosteroid into the affected cord, followed by division of the cord by 15 gauge needle, later modified by Foucher. He gave no corticosteroid injection and cord is divided at 2 or more level by using 19 gauge needle. It is usually done under local anesthesia and tourniquet control. Isolated palmar cord with moderate MCP joint flexion, but failure rate was 15 to 19%. Open fasciotomy was first described by Dupuytren. Here, division of the disease cord was done under direct vision and suitable for isolated MCP joint contracture. Limited longitudinal incision was given on the affected cord. Cord is visualized, isolated, and then divide transversal. In local fasciectomy, a longitudinal or jetplasty incision is given over the involved cord. Resection of 1 to 2 cm of the cord and residual disease aponeurosis is left behind. There are noticed complications such as palmar hematoma and neurovascular injury. Regional fasciectomy is the mainstay of operative treatment. Excision of all macroscopically abnormal tissue within the palm and finger. It is performed under regional or general anesthesia. We use brachial tourniquet, lathe or taper hand, and loop magnification. Longitudinal incision with jetplasty or zigzag Brunner type incision is given, as both provide good exposure. Adequate exposure is mandatory for proper dissection of the diseased tissue and preservation of the neurovascular bundle. And also we should preserve vascularized skin for closure. And this incision, zigzag or Z incision, allow skin lengthening and also prevent scar contracture. For faster space, T incision with jetplasty or 4-flaplasty. Removal of the diseased tissue from the finger is the most delicate part of the surgery, and here we should preserve polysystem, and it is must. Some authors also prefer radical fasciectomy, where extensive dissection of the palm and digital fascial structures are done. They remove both the diseased and normal palmar and digital fascia. But as extensive dissection was done, postoperative complication was more, such as hematoma, skin necrosis, etc. So this is largely abundant now. There is another option, dermatofasciectomy. Here excision of the involved fascial structure of palm and finger and also the overlying skin. It is indicated in treatment for recurrent disease with extensive cutaneous involvement. After excision, wound is either allowed to heal secondarily or by full thickness skin graft. Postoperative care is very important. We prefer early movement to maintain joint mobility. Extension is planned to reduce development of the contracture. And for those patients who underwent enzymatic or percutaneous fasciectomy, we give bulk dressing, and dressing usually changes on third period, and patient is advised to use the hand normally. For those undergoing fasciectomy, volar is planned with MCP and PIP joint placed in maximum extension and leaving the unoperated finger free. Fingertip free to allow for assessment of perfusion. And if we done primary close, then movement will start from 3 to 5 postoperative day and stitch out usually on 14th period. If full thickness skin graft is given, then dressing changed on 5 postoperative day and movement is delayed up to 7 postoperative day. Hand therapy is given and target is to recover full extension followed by restoration of hand function. If tenodesis is performed, then immobilization for 3 weeks, then dynamic splinting. Postoperative complication usually depends on the procedure performed. Late complication usually includes complex regional pain syndrome, scar contracture, disease recurrence. 15% patient may need re-excision. Some secondary procedures may also need it. Even there is some option for amputation also, and management of Dupuytren disease is remain a challenge for hand function. Thank you all for patience hearing.